Okay, how's that?
Great.
Okay, thank you, everyone. Good morning. Thank you, Dr. O'Brien, for your kind introduction. Today, I'm presenting a case from Duke Raleigh Hospital as part of the Division of Hospital Neurology. We have a gentleman, a 79-year-old gentleman with a history of prostate cancer, hypertension that presented to the Duke Raleigh ER on June 3rd with a headache. They performed a CT of the head, a CT angiogram of the head and neck. The vasculature was normal. However, the CT of the head demonstrated some sinusitis. He was treated with Toradol and Augmentin and discharged home. He returned to the ER on June 4th with a headache, and they did not have any additional findings, and they continued the present management. However, he then returned to the Duke Raleigh ER in the late evening on June 6th with increased right-sided headache, right eye pain, and blurred vision. On his laboratory studies at that time, it was notable for hyponatremia of 118. On neurologic exam, his temperature was up to 38.3, was febrile, with a blood pressure 159/74. He was mildly somnolent, but easily alerted to verbal stimulation, alerted to voice. He followed commands. His speech was clear and no apparent aphasia. On cranial nerve exam, his pupils are 3 millimeters and equal and reactive. However, there was noted to be severe right ptosis. The right orbit appeared significantly edematous with scleral injection. Eye movements were full in the left eye, but in the right eye, the eye movements were decreased with decreased excursions in all directions. There was still some movement, they were decreased in all directions. There was mild decrease of the right nasolabial fold, but the smile was symmetrical, palate elevated symmetrically, tongue was midline, normal shrug. His facial sensation was intact. Motor and sensory exam in the extremities were normal, reflexes were 2+, and he had normal finger, nose, finger testing. At this point, with severe right ptosis and multiple cranial neuropathies in the right eye, my concern was for something perhaps localizing to the cavernous sinus. And that can have a broad differential of different infectious etiologies, neoplastic, infiltrative, a couple different things. So we ordered some imaging. The hospitalist team had completed a CT of the sinuses prior to consulting me. And so that demonstrated a pacification of both the right and left sphenoid sinus, dehiscence of the right sphenoid sinus, the right foramen rotundum. There was enlargement of the right superior ophthalmic vein concerning for thrombosis. Following consultation and exam, I advised the following studies: MRI of the brain and orbits with and without GAD, CT angiogram of the head and neck, and a CT venogram. I'd like to share with you some imaging from the MRI of the brain. On the left image is the coronal image of the orbits, demonstrating enlargement of the right superior ophthalmic vein. In the central image, we have images concerning for bilateral cavernous sinus thrombosis. And in on the right image, we have concern for enhancement of the leptomeninges, suggestive of spread from the sinuses. The CT angiogram of the head and neck did not show any vessel occlusion. All the vessels were patent. CT venogram showed patency of the remaining dural sinuses. Following obtaining of these images, we consulted infectious disease, ENT, and neurosurgery. He was started on broad spectrum antibiotics with vancomycin and cefepime. ENT performed a bedside scope, which was concerning for invasive fungal versus bacterial sinusitis. And he eventually went to the OR later that afternoon at Duke Raleigh for debridement and sphenoidotomy. Again, they were concerned for fungal invasion as there was not a lot of significant purulence on exam. He was transferred to the Duke University Hospital Neuro ICU in the evening of June 7th to continue his care. In the Neuro ICU at Duke, he was extubated the next day and antibiotic coverage was expanded. They obtained CSF analysis demonstrating a significant lymphocytosis with 71% neutrophils. They started heparin about 24 hours after the sinus surgery due to the thrombosis of the superior orbital vein and bilateral cavernous sinuses, and blood cultures were sent. Ophthalmology evaluated the patient, demonstrating slightly elevated pressure in the right eye, but within normal limits, but he remained with right ptosis and decreased extraocular movements. Eventually, they completed a repeat MRB without other thrombosis, and the heparin was eventually discontinued. Sinus cultures came back with the pathological organism of Citrobacter coceri, and this was confirmed also in blood cultures on June 12th. CSF cultures remain no growth to date. Infectious disease advised continuing cefepime, vancomycin, and metronidazole. The patient clinically improved, his eye movements improved, the ptosis improved, and he eventually was discharged home this past weekend. So I want to take a minute to talk about cavernous sinus thrombosis. And as we know, these represent paired deep venous sinuses. They are especially susceptible to spread with septic infection, and they're at high risk from the face, draining through the superior ophthalmic vein and what they call the danger triangle surrounding the nose and the corners of the mouth. They drain through the vein and the deep facial vein, and therefore are susceptible to infection. However, cavernous sinus thrombosis can also be caused by non-septic etiologies, including a hypercoagulable state, post-surgical complications, neoplastic infiltration, or dehydration effects of drugs and medications. Prior to modern era of antibiotics, the mortality approached 100% when patients had cavernous sinus thrombosis. However, with antibiotics, the mortality is decreased, but now closer to 30%. Cavernous sinus thrombosis still causes significant morbidity, and it can extend to causing stroke, ophthalmoplegia, and blindness. About 25% of the time, this can be associated with thrombosis of the superior ophthalmic vein. Oftentimes, the best imaging studies include MRI, MR venogram, CT venogram to help with this diagnosis. Another thing to watch out for on the CT studies is narrowing of the internal carotid arteries passing through the cavernous sinus, although in most cases, this can be reversible with treatment. And patients should be monitored for extension to other dural sinuses. Treatment of septic cavernous sinus thrombosis, there's three main modes of treatment. One is surgical, in which you have functional endoscopic sinus surgery to debride the area and drain any purulence. Antimicrobials are the mainstay of treatment. There's a high frequency of staph infections, strep, anaerobes requiring broad spectrum coverage in these patients. However, antifungals are considered in high-risk populations, including patients that are diabetic or immunocompromised. Anticoagulation is also used in the treatment of cavernous sinus thrombosis, although this is somewhat controversial. Current thoughts in most of the articles that I read suggest anticoagulation of unilateral cavernous sinus thrombosis to prevent propagation and extension to bilateral thrombosis. They also recommend anticoagulation of superior ophthalmic vein thrombosis to prevent extension to the cavernous sinus and prevent ocular morbidity. However, in this case, the patient already had superior ophthalmic vein thrombosis as well as bilateral cavernous sinus thrombosis. So the literature was unclear on the utility of anticoagulation once both bilateral cavernous sinuses had evidence of thrombosis. Some studies indicated decreased mortality with use of anticoagulation. Others demonstrated decreased morbidity in terms of recovery of ocular function. However, in most cases, the literature suggested using anticoagulation in these patients is overall safe as long as there's not any evidence of hemorrhage. However, the mode of anticoagulation and the duration is unclear. That's the end of my case, and I'd like to take a minute to thank all of you for listening today, as well as to thank you for the various physicians that helped organize and help with this patient, and I appreciate all of your help.
Thank you very much, Beth. That's great. All right, to introduce today's grand round speaker, I'm going to throw it to Chris Eckstein.
Thanks, Rich. Good morning, everyone, and welcome to the last speaker in our Chief Resident series. So there are others have set a high bar for Ben. We'll see if he can clear it today. Ben, for those of you that don't know, came from Tennessee, where he did his undergrad at Tennessee Tech, and then his medical school at East Tennessee State University, James Quinlan College of Medicine. I have confirmed it's a real place with an actual accreditation. I check it every time I happen to see it listed. But Ben's been with us for residency the last 4 years, and he's actually going to go on to practice next year with telespecialists, and hopefully will do very well there. And today he's going to be talking to us about resident burnout.
Thanks for the introduction. I promise I'm a real doctor. Let me see if I can get this up and sharing. Nope, don't mess up on me. And
Here
All
it
right.
comes. We got it.
we got it. All right, let's see if I go to slideshow, if it messes up and goes presenter view or the regular view. Nope, looks like.
There
Are
it
you,
is.
are you
Yeah.
guys seeing the actual presentation?
Yeah, we see the main presentation with the little slides on the side.
Okay, no, I want the whole kit and caboodle.
What
I
at the
don't know.
bottom, Ben, where you got the little monitor thing? Bring it down, 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 down. Now to the right, 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 right. See the little monitor thing? No, over one, over one. One more, right, to the right, to the right, to the right, to the right. No, other way.
All right, this one.
All right, boom. Hit
See if that does it. I knew I was going to run into technical issues on this. Is it actually showing the slideshow? I don't think it's showing the slideshow.
No.
Let me see if I can switch it over, because it's interesting putting it like on my other screen for some reason, putting the actual slideshow over there.
Yeah, you folks make fun of me when I have my Zoom issue.
I knew you were going to get me on this one. Resume slideshow. Oh, it's just going to keep messing things up on me now.
Yeah, the other one's fine.
Okay. All right. You know what? I'll just go with this. It's fine.
We
All
don't
right.
see anything right now, Ben.
Oh, man, come on.
You got to do the share screen again.
Just going to mess my day up. I'm going to get so many text messages about this.
Okay,
All right.
that looks good.
Can you see it now?
Yep.
All right, we'll just go with this. All right, so today we're going to talk about burnout. I appreciate y'all coming to listen to me mostly ramble. I'm mostly going to focus on the problem as a whole and add a little sprinkle of residents as well. So disclosures, none in particular. I am a resident, so I'll try to stay objective as I can. And I'll go ahead and give fair warning that there is a little bit of discussion on some sensitive mental health issues. So just fair warning that that's coming up. So covering objectives, we're going to define an overview burnout. We're going to frame negative consequences. We're going to discuss various sources of resident burnout in particular. And then lastly, we're going to elaborate on some possible solutions, interventions, and other things people have done. So defining burnout, burnout was first described in literature by psychologist Herbert Freudenberger in 1974. It is often defined as a mental and physical exhaustion. A later model by Hobfell and his group, or her group, I didn't look, was popularized in the 80s and 90s, in which burnout stressors resulted from one or more of the following. 1, a loss of material or psychological resources. 2, a posed threat to those resources. And 3, inadequate return on investments made to maximize material or psychological resources. And burnout is the result of repeated investment in work resources without adequate return on that investment. And this model further stipulated that once an individual reaches burnout, they will be more careful on how they invest future motivational resources. Nowadays, burnout is commonly obtained from questionnaire data, frequently from the Maslow Burnout Inventory, or MBI. It's divided into 22 question items that focus on 3 important aspects of burnout syndrome: emotional exhaustion, or work exhaustion and feeling of being on edge; depersonalization, which is the lack of empathy and impersonal responses; and reduced personal accomplishment, or reduced sense of achievement and competence at work. And I have an example of that questionnaire on the side, typically like questions like, I feel emotionally drained, I feel used up at the end of the day. And usually those are ranked on a scale. So when compared with the general US population, physicians are more likely to have symptoms of burnout and dissatisfaction with work-life balance. In fact, from studies, those with MD and DO degrees are more likely to have burnout than those with bachelor's, master's, or other professional or doctoral degrees. Sociodemographic factors associated with higher risk include essential worker staff role, young age, unmarried, divorce, and female providers. The prevalence of burnout varies from study to study, and most studies are actually pretty heavy limited by non-response bias. Pretty much everyone that I read across typically only had a 15 to 30% survey return. So it kind of makes you wonder if those who are burned out or don't have time to fill out surveys and just delete that email when it comes across their desk. So everything kind of has to be taken with a grain of salt. There's also additional limitations on the number of studies published on residents as opposed to physicians as a whole. And from best estimations, approximately 50% of physicians and medical trainees report at least one symptom of burnout. I'm gonna have to mute my phone because you guys won't stop texting me. Specialties with more shifts and more inpatient emergent work tend to have higher rates of burnout. Depending on which studies are referenced, residents in OB-GYN, emergency medicine, neurology, and general surgery tend to have the highest rates. I found this one article that actually listed burnout scoring by specialty over the course of 3 different years, 2011, 14, and 17. And you could see the mean kind of in a blue tinge in the center. Emergency medicine tends to report high burnout, OB, family medicine, neurology, PM&R, whereas on the lower end and the better end of the spectrum, pediatric, psychiatry, ONT, PATH, stuff like that. So thankfully, awareness of burnout has been increasing with time. I generated this graph actually from Scopus, basically pinging any publication that had the comment word or anything related to burnout. And this is the number of publications that include that by year. And you can see at least the most complete year, 2021, had over 5,000 actually. And then more interestingly, a lot of these studies actually came from the United States. I don't know if that's a publishing bias because of what I can see or if that says something different, but I'll let that be the eye of the beholder there. So let's talk a little bit about negative outcomes and consequences of burnout. So burnout can present with physical and somatic symptoms that may interfere with daily function, including headaches, fatigue, GI distress, sleep disturbances, and appetite changes. Psychological changes can also manifest with mood disorders such as depression, reduced concentration or procrastination, delaying of necessary tasks. Burnout increases the risk for suicide and suicidal ideation and substance use and abuse. Some studies report that burnout can result in poor quality of care, increased medical errors, patient or provider dissatisfaction, and attrition from the medical practice as a whole. So let's talk a little bit about errors in clinical care and what data exist out there. Burnout physicians self-report higher frequencies of providing suboptimal care and also themselves self-perceive that they have made medical errors. One study of 700 surgeons roughly who reported making medical errors had higher mean scores of emotional exhaustion, depersonalization, and lower personal accomplishment scoring. However, there's not any dedicated studies that track burnout scores before medical errors occur. So this study with 700 surgeons is a little bit more chicken or the egg. Did the mistakes cause you to be burnout, or were you burned out and then made mistakes? However, additional studies have shown that self-perception may not be the only issue, as one other showed that higher burnout scores had lower patient satisfaction scoring, which was often the result of either poor physician engagement or communication with patients. Talking a little on depression, as expected, higher rates of burnouts are associated with higher rates of depression. However, physicians are less likely to self-report depressive symptoms and less likely to seek treatment. What was really great, at least when I was going through trying to find some data, 2019, the ACGME actually posted quite a bit of their survey data, so I was able to pull a lot from them. In 2016, you could see here on this graph from approximately 11,000 residents, about a quarter, 25%, had symptoms or screened positive for depression on PHQ-2 assessment. I tried to find some general population data, and I actually was able to pull some information off the CDC on a almost equivalent population size. And in comparison, you can see that looking at symptoms of depression and positive screen for depression, the comparison there, 16 versus 4.2% versus 10 and 3.9%. So definitely a lot more popping up positive with symptoms, signs, and whatnot of depression. And then attrition from the same ACGME data in 2015 on 12,000 residents asked if they would select medicine again as a career. pretty much a third of them said that they were somewhere between not sure and definitely not. And they went as far as to actually break that down by specialty. I found this one actually really intriguing. Even though emergency medicine notes higher rates of burnout, equally their satisfaction was actually higher. 78% of them said that they would do it again, followed by family medicine, psychiatry, pediatrics, internal medicine. Whereas in the opposite flip side of the coin, you have diagnostic radiology, where pretty much half of them are saying, I'm not sure, or no, I would never do this again. And neurology, interestingly enough, not too far from that either. Breaking down on substance abuse, across various studies, increased levels of burnout are heavily associated with substance abuse. In prior surveys from many years ago, substance use among all physicians was approximated to be about 10%, which was equivalent on par with general population data. However, more recent years, there's been an increase specifically in alcohol use. Most recent data from 2015 that I could find on 7,300 survey responders suggested that greater than 13% of physicians have alcohol abuse or dependence, compared with the general population at 6.2%. Marriage and divorce. Interestingly, divorce rates among physicians are actually lower compared with major professions in the general population. I found this interesting. I had to put this here. Divorce among physicians is higher for men who work less than 40 hours a week, while it is higher for women who work greater than 40 hours a week. Take that for what you will. Despite the low divorce rates, some speculate that the quality of marriages can be heavily impacted by stressors in the medical field. A separate survey of 7,300 physicians, and they were able to get 900 partner responses as well, found that of those who reported recent work-home conflicts, 50% were more likely to express symptoms of burnout. A smaller study showed that physicians who spent more time on night call shifts had significant negative impacts on self-reported quality of their relationships. Suicide. So from a separate study of ACGME data spanning 2000 to 2014, the second leading cause of death for residents is suicide, only behind cancer. Temporal patterns show that higher rates of suicide are earlier in training, though the overall incidence of suicide is less than compared with age-matched general population. The risk of suicide across physicians as a whole with the entire lifetime is actually higher than the general population. There are estimated to be approximately 400 physician suicides a year, and comparing with general population, the relative risk of suicide is 3.5 for men and 5.7 for female physicians compared with the general population. I actually was able to make these own graphs just so you have a little bit of a visual comparison. This is the same resident data on all the deaths that they had listed, compared with the general population, CDC, age matched roughly 25 to 35 spectrum. And you can see with the general population, accidents at roughly 33% is the major cause of deaths in our age group, where if you compare that, accidents on the left is kind of more in the category of like 15%, suicide at 12.8% versus suicide at 20%. And even though cancer is our leading cause, if you compare with the general population, it only makes up 8.6%. So I guess we're not running out and doing a bunch of crazy stuff and driving all the time, but it's just a little bit interesting to look at this data. So let's talk a little bit about sources of resident burnout in particular. Between the ACGME and various other articles, factors that can cause burnout include, but are definitely not limited to, heavy workloads, low flexibility, sleep deprivation, money and salary issues, lack of support or teaching, poor work-life balance, disorganized administration, overbearing clerical responsibilities, interpersonal problems, family issues, and the list could go on. I actually pulled this really extensive list from a Mayo article, which I'm not going to go into, but if anyone wants to go back and look at it, just about anything you could think about is hidden somewhere in there. So I wanted to break down just a couple of these items. I don't have enough time to go into absolutely everything, but some of the things that I feel like folks find most important. So work hours, depending on the specialty and balance of inpatient, outpatient work, most residents work somewhere between 40 to 80 hours a week on average. The running average for most specialties, though, is greater than 60 hours a week. And to the left here, I actually pulled some data from the AMA FRIDA database on hour breakdown by specialty. You could see neurology hidden in here at somewhere just about 65 hours a week. And I bless our neurologic surgeons because they're hitting that 80 mark just about all the time. So just interesting data to look at there. So I wanted to break down a little bit of the back history on work hours just so I can frame a little bit more of this conversation. So the short history in the United States is prior to the 80s, there was limited standardization of work hours. In 1984, there was the Libby Zion case in New York, in which there was a presumed accidental death of a college freshman, which they believed to be the result of a 36-hour shift. It gained quite a bit of political attention. In 87, a New York commissioner appointed a separate committee which recommended 80-hour weekly limitations. Though adherence to such was really poor, there was a lot of fighting amongst whether it should be the case or not. Between 89 and 93, and this is prior to the age of like ACGME kind of ruling it all, there was various residency review committees that, some of them placed 80-hour work restrictions, but not all. Between 93 to 2002, there were minor revisions that were made until the ACGME kind of became its own independent corporation in 2002. And then following that, 2003, ACGME formally announces duty hour restrictions across all specialties and trainees, 80 hours a week, the 1 day off and 7, maximum 24-hour shift, plus or minus a few hours for extra clinical duties. 2011, ACGME restricts PGY1 interns to 16-hour shifts max, but then in 2017, ACGME rolls back that 16-hour restriction after they did a 5-year survey, which showed that there was no evidence of patient harm or detriment to education. So how are work hours handled in other countries? That was kind of a curiosity question that came up for me. America is definitely not always the standard for everything. So in the European Union, the EU actually enacted the European Working Time Directive in 1998, which actually had a maximum work week of 48 hours, minimum of 11 hours off per 24-hour window of time, and 1 day off and 7. Though, it's pretty restrictive on the total number of hours. A lot of people felt that was a lot, and compliance is not necessarily full across the entire European Union, but at least the UK, Germany, Denmark, Sweden, Finland, Netherlands, and Norway actually do report compliance with this. And there was a separate 2010 report in the UK that tried to assess, can residents actually get high quality medical training delivered in just 40 hours a week? And that survey actually showed that they felt they could. Canada also does something different as well. There's no complete national agreement on work hour restrictions. However, resident duty hours are pretty much negotiated between resident associations, which enact analogous to resident unions for the most part. And that's between them and their provincial jurisdictions for which they train. Interestingly, in 2011, there was a big case that came up in which a local arbitrator ruled that a 24-hour continuous duty posed a danger to residents' health. And this brought significant public attention to the issue, after which in December of 2011, a 16-hour maximum per shift was placed for all residents across the country. So breaking down into salary, on the right, I actually have Medscape data of average salary per year training, which actually corresponds pretty closely with AAMC data as well. When comparing an average salary of roughly $60,000 by the mid-year of training at 48-hour weeks or 48 weeks in an academic calendar year and an average of about 65 hours a week, that comes out to about $19.20 an hour. This is compared with the median general population income, at least from 2021 U.S. Bureau of Labor and Statistics data I could find. Median income is 22 an hour. The mean is 28 an hour. Accurate resident salary, I tried to find this information for other countries. It was a little bit more difficult for me to ascertain, but at least vague answers that I could find, it seemed relatively equivalent pay for often fewer hours.
Yes, shampoo.
Someone's mic is on. So going into salary a little bit more, how much are residents worth? Questions come up a couple times, but I feel like it gained quite a bit of public attention in 2019 after a particular case in which the ACGME withdrew accreditation from the neurosurgery department at the University of New Mexico. 8 residents were displaced elsewhere, and to replace their equivalent worked hours and training, they ended up having to hire 23 APPs at approximately 3 APPs a resident. That's a 5 to 6-fold salary cost that was covered by the hospital system in that case. And I think in more recent news, I saw that they were actually getting their neurosurgery residency back. But I think it should further kind of catch your attention that the largest private healthcare system in the nation, HCA, is also the largest sponsor of GME with 304 programs, over 5,100 available positions at 61 hospitals across 16 states. And many of you may be asking why. Some speculate, I'll say some speculate that there is a modest profit behind having resident physicians. And I'll go back to kind of how residents are often funded for the most part. In 1965, Congress enacted the Medicare Act, which provided resident medical education funding through what's called direct GME. Additional financial support was negotiated for indirect GME in 1987 to theoretically cover other miscellaneous residency expenses such as unnecessary testing, patient care efficiencies, and kind of just about whatever else you can claim. A JAMA published article covering dates from 2000 to 2015 noted that a total subsidized payments in both direct GME and indirect GME increased from 117,000 to 138,000 per resident annually. And I have this graph listed here off on the side. All of this information on every hospital who claims GME funding is actually publicly available through cms.gov. And just out of curiosity, I looked, and Duke claimed $60.1 million on all the residents that they had, which I think was roughly about 700 in 2020, which was the most recent complete data. And that doesn't include additional GME funding that actually comes through VA healthcare systems. So I try to do a little extra literature research, and very few have directly studied and published profit margins behind having a resident, except there was a really large publication by the RAND Corporation in 2013. It was like a 47-page document, which they commented that Medicare subsidized internal medicine resident positions could theoretically profit up to $250,000 annually when subsidized. So, and that didn't even include like procedural residents. So I think they had a separate category on like cardiology fellows, and talking about how like they could profit up to roughly the mid 300s. So out of my own curiosity, I actually took the time to go through the entire cms.gov Excel sheet, which took me about 2 hours, found all roughly 61 of HCA's hospitals. And in 2020 alone, a total of $392.1 million was collected by all HCA facilities in total for a claimed 3,334 residents, which sums out to about $117,000 each. And at an average salary of about $60,000, that leaves about $57,000 overhead for whatever educational expenses may be at play. And this does not include whatever productivity revenue is created by said residents. So breaking away a little bit from that, let's talk about sleep. Finding dedicated studies on residency, shift work, sleep, PGY level, actigraphy, all of that can be a little bit sparse. Like most of the studies that I would find typically only had like, we studied 8 residents and how they sleep. I'm like, that's not too helpful. But I found 3 studies that I thought had decent enough numbers to talk about. One such of 137 interns on inpatient services using wrist actigraphy found that they slept on average about 6.9 hours a day. On night call shifts, they slept about 2.2 hours on average, followed by only a 2.8-hour nap post-call. Interns slept about 1.6 hours less when they were on night or call shifts compared to regular day shifts. Assessment with psychomotor vigilance testing found that their alertness was impaired post-night shifts pretty badly. In 2020, another study of 32 medical and surgical residents of varying years found that they slept about 7 hours daily, but what caught their attention is that their sleep was vastly varied. So it would range on an order of plus or minus 3 hours. Reported quality of sleep remained poor across all years. At the low point, most residents were sleeping at about 5 hours, which significantly raised their risk of motor vehicle accidents in the subsequent 24 hours following such a sleep period. A separate survey of 201 residents found that 90% reported poor sleep quality on PSQI, 86 reported subjective issues with concentration, and this had a higher correlation with those who were working 3 or more call shifts a month. I ironically state that some hospitals acknowledge this as a safety risk by providing a free transport home. And then lastly, I have a category that I mostly just call big no-nos. There are other sources of burnout that should be mostly characterized with a zero tolerance policy. Those include belittlement, intimidation, retaliation, disrespect, racism, sexism, unethical behavior, harassment, exploitation. And I tried to find what information is out there that we know about this. And regrettably, I came across this meta-analysis in 2014 covering 51 other studies that found that almost 60% of medical trainees had experienced at least one form of harassment or discrimination during their training. Typically, this came in the form of verbal harassment. And interestingly, I was not expecting this. Consultants that you call were cited as the most common source of harassment and discrimination, followed by patients. So, interventions, where do we go from here? And I think the answer is resiliency. It's the key to burnout. I'm kidding, it's pizza parties. Physician wellness is definitely an important aspect, but it's only one small part of the process. Most studies have shown minimal to modest benefits using wellness programs, apps, etc., technology. And those who study longevity, benefits are often short-lived, as burnout, it mostly stems from systemic issues. So organizational versus physician interventions. I've came across this one systematic review of 19 other studies on burnout interventions that were categorized as either organizationally based or physician based. So organization focused on workloads, flexible scheduling, team building, quality improvement, enhancement of teamwork on site, leadership skills, and physician based focused on mindfulness, stress reduction, self-confidence, communication skills, exercise. Yoga is probably in there. This study found that organizational interventions had higher results on burnout scoring, and physician-focused interventions were only effective when coupled with organizational adjustments. And you can see some of that data pulled out here on the right, with category A being organizationally based and category B being physician-based studies. So at this point, I want to talk about a really, really good article that I kind of came across in 2017. Mayo Press posted a really good article on burnout. Authors of this article asserted that burnout is precisely such a system issue. Extensive evidence suggests that organization and practice environment play critical roles in whether physicians remain engaged or burn out. And they further went on to mention that casting the issue as a personal problem can only lead to individual physicians to pursue solutions that are personally beneficial but detrimental to the organization and society. And in the same article, they actually listed 9 organizational strategies to reduce burnout. So I actually really wanted to cover those over the next few slides here. So strategy 1, acknowledge and assess the problem. Simply having an open dialogue with physicians and trainees can be therapeutic in and of itself. Individuals often find it meaningful to have discussions with leadership or administration about active or concerning issues. And it should also be apparent that monitoring physician well-being on acknowledged problems is equally important. Strategy 2, harness the power of leadership. Through Mayo and their own internal surveys on leadership, they have their own 60-point scale, and they found that roughly for every 1 point increase, this resulted in a 3.3 decrease in burnout and a 9% increase in satisfaction scoring. And so they kind of went on to kind of characterize what's needed to have a good leader. Good leaders should have the ability to listen, develop, and specifically lead other physicians and trainees. Leaders themselves should also be developed for the role in specific. They should be prepared and properly equipped for the role that they're going to take on. Performance of leaders should be regularly assessed by the individuals they lead. And lastly, they really, really hark on this one. Organizations must also have the courage to make leadership changes when necessary based on scoring. Studies have shown that physicians who spend at least 20% of their time on professional activities they find personally meaningful, that could be working with underserved, research, education, whatnot, those individuals often have less burnout, and good leaders should strive to facilitate this professional development in the individuals they lead. Strategy 3, develop and implement targeted strategies. Focusing on the aforementioned acknowledgement and leadership groups, it should be feasible to determine what's called high opportunity units or high opportunity items. Such units or items should be determined through internal metric scoring surveys, or simply they can get ascertained from direct communication. And interventions for those items should be targeted, specific, and hopefully come with measurable outcomes. Strategy 4, cultivate community at work. Physicians and medical trainees deal with unique and emotionally challenging tasks. Peer support remains an important role in bolstering morale. Both formal and informal gatherings are equally effective, but avoiding cultural isolation is key. Intentional measures should be pursued to improve upon these factors, whether it entails conferences, physician lounges, social outings, or whatnot. Strategy 5, use rewards wisely. The authors of this article caution pitfalls of direct compensation models for payment. With direct compensation models, physicians can mainly use 3 ways to increase productivity or revenue, one being shortening time per patient, 2, ordering more tests or procedures, and 3, working longer hours. The first 2 approaches tend to erode quality of care, while the third can increase burnout. There's no necessarily right or wrong answer yet to this issue, but they do impress upon that salary pay models can alleviate some of these issues. Some institutions have included patient satisfaction scores and physician self-care wellness into pay models, but impact on that is kind of either low or to be determined. Strategy 6, align values and strengthen culture. It's important for organizations to be mindful of factors that influence culture, assess ways to keep values fresh, and periodically take stock of whether their actions and values actually align. Honest appraisal of the organization from staff can help determine where weak points may reside in those features. Strategy 7, promote flexibility and work-life integration. Apart from residents previously mentioned above, about 45% of all physicians work about 60 hours or greater per week, compared with less than 10% of the general population doing that. Providing physicians with the option to adjust work effort by either flexible hours or less hours with an appropriate reduction of pay can allow for better balance between personal and professional obligations. Although not always possible, they really exert this one. Organizations should seek to maximize flexibility to the greatest extent possible. It is also important to re-examine the structure of vacations, coverage for important life events, approach to scheduling, and strategy for weekends and nights. Strategy 8, provide resources to promote resilience and self-care. Although the primary focus for organizations should be to optimize their own environment, they should also provide resources for individuals to fly. I think someone else is coming through on the mic. Maybe walking. They should also provide resources for individuals to fight burnout. Regrettably, most medical centers have made individual-based approaches the centerpiece of their strategy. When individual-based measures are placed without sincere system-based solutions, these measures are often met with skepticism, resistance, and cynicism. And then strategy 9.
I'm looking to see who's marching, Ben, but I can't see anyone with an open mic.
You're fine. I think I see Carolina showing up. There we go. I think I got it. All right. So strategy 9, facilitate and fund organizational research. They impress that Vanguard institutions should put forth effort to develop and publish evidence-based strategies they have implemented internally so that we can all benefit and learn and improve as a whole. And so I also wanted to include this because I feel like I can't talk about burnout without touching upon this topic of self-advocacy. So for residents, is there something else that they can do? Some residents who have felt that systems are not advocating enough for them have taken to self-advocacy. Across the nation, certain residents have organized to have their voices heard. He who shall not be named, if the GME is listening, unionization. If they're not here, I'll say unionization. But just this month, the AMC themselves actually posted a rather thorough article on the topic of unionization, just giving pros and cons. So I kind of wanted to relate that information here. So in the US, resident unions date back to 1934, but with ensuing legal battles and blocks, it wasn't really until 1999 when the National Labor and Relations Board ruled that medical residents should be deemed as employees and thus have the right to unionize. Today, roughly 15% of US house staff covering more than 60 hospitals are represented by the nation's largest union, which is the Committee of Interns and Residents. A smaller portion have joined local unions or more broad groups such as the Union of American Physicians and Dentists. And there's a lot of challenges for those who are interested in unionization. It's definitely no small task. Specific steps tend to vary state by state with labor laws, but starting this process typically involves residents indicating interest with union cards and signing. If enough do, and this usually requires a very large majority, the next step is for the hospital to voluntarily recognize the bargaining unit, which historically doesn't happen often. If not recognized, the next step is a formal vote overseen by the actual National Labor Board and Relations. And if that passes, and this is the more arduous part, there's contract negotiations. It covers multiple details ranging salary, family leave, textbooks, parking, benefits, and just about anything you could probably make an argument on. Upside to unionizing. Those who have unionized have seen various improvements between increased pay, better flexible hours, additional benefits such as transport, housing, technology stipends, whatever they try to negotiate. I saw this picture pop up when I was Googling, and recent LA County residents unionized. Some argue that unionization can improve healthcare with better cared for residents and supporting diverse individuals in the physician workforce. The downsides. Although federal funding helps to pay for resident salaries, hospitals worry that additional and unforeseen expenses involved in resident training could be pretty impactful. Some residents and others worry that unionizing or striking could undermine trust with patients and local communities. Across all residents, there are major differences from specialty to specialty, and as such, interests in contract negotiations may differ, and benefits to one group may not necessarily benefit all. Like, for example, one argument I came across was, surgical residents still have to meet a case quota to graduate, so necessarily having work hour restrictions doesn't always help them. Contract negotiations could fray relations between residents and admin hospital leaders. Not always does unionization result in significant improvements in certain situations. I came across this one study in 2021, which covered roughly 5,700 general surgery residents, and they found that those within unions did not have any improvement in burnout, suicide, job satisfaction, duty hour violations, mistreatment, salary, or educational environment. Although it was only 10% of those surveyed 5,700 responders that were actually in unions, so the power of that may be a little bit limited, and it's also biased by the focus of looking at just one specialty. So I'll let you take that information and all and for what you will. So lastly, I'll close here from the MBI author herself. If all the knowledge and advice about burnout and how to beat it could be summed up in one word, that word would be balance. A balance between giving and getting, the balance between stress and calm, and the balance between work and home. And I will briefly show the multitude of resources that I had to spend my time getting all this information from. And I will stop there and see what questions or comments people want to have.
Thank you, Ben. So, Ben, I hate to ask the first old guy question, but when I was a resident, we were on call every other night half the year and every third night the other half. We hadn't even heard of the word burnout. We were tired, exhausted even. What's the difference, do you think?
It sounds like you were burned out. So I think the difference between then and now is probably a lot to do with just awareness of what we're feeling. We'd like to talk about our emotions more, but I mean, the problem has always been there. Has it been getting better with time? Yeah, I mean, going back through on this US history triad, it really kind of appalled me to read what people are doing prior to like the 80s, 90s, and before that point. But I think the problem is still we're all just there. Humans were not necessarily built to stay awake for 24 hours straight. We were built to go to bed after being up during the day and go to sleep mostly at night, or at least flip-flop that entirely. So I think as long as we're working past what biologically we were meant to do, we're always going to feel something. Tired, exhausted, emotionally drained, unfulfilled. It's all different to the perspective.
All right, Noreen, you have a question?
I do, but I just wanted to add one more point to your question, Rich. I think that, over the course of the decades, the bureaucratization and the administrative process of the healthcare system has become way more complex, which I think has likely added to a lot more stress on residents too.
Yeah, we didn't even write notes, Noreen. I mean, we just a few handwritten things in a chart was pretty much it.
Right. And, our joke in intern year was there were glorified documentations. So that's kind of the change that I think is attributing to burnout. I remember as a neurology resident, the first year when Mr. Clean trial came out and this change in the level of acute stroke codes, which added a lot of stress to resident work hours as well. So I would imagine that it's just the complexity of the healthcare system over time that has also contributed to burnout. And my question was specifically regarding a time where I imagine there's a lot more risk of burnout, which has to do with, maternity leave. And after you come back from maternity leave, having to juggle childcare and personal responsibilities in addition to the rigorous schedule. I'm just curious if there's been any studies looking at that, which is a time of vulnerability for a lot of families.
So you bring up 2 points that I always like bringing up this graph on the complexity of administration and bureaucracy in healthcare. And here's my favorite picture of the Bureau of Labor and Statistics that compares from 1970 to 2015, the number of physicians compared with growth in hospital administrative positions. And that should kind of bother you some. On the topic particularly of women in the workforce and maternity leave and coming back, they've studied at least seeing that we see female physicians are often more burned out, at least on this study that I came across on alcohol abuse and dependence. It did comment of the female providers who replied that there was actually higher use of alcohol compared with men. And a lot of the at least commentary and discussion in those articles state factors like maternity leave, childcare, and extra factors, other societal stigmas that come with the process that make it much more challenging.
That's a great slide, Ben. I did a screen save of that.
Its picture appalls me every time I look at it.
I think you could put the same thing about medical students to deans at medical.
Probably, and compare that with at hike of tuition fees by year, probably with change in quality of education.
Right. Mark Skeen had a question. We have a bunch of questions out there. Mark?
I'm glad.
Mine was just an observation that my personal experience is that I think burnout has more to do with emotional things than the physical demands. And that reflects maybe what Rich was saying. We worked a lot harder and under a lot more duress in the past. But I think the frustrations, I'll just leave it at that, and the lack of emotional reward has changed dramatically. And to me, that's what contributes a lot to burnout.
I would agree with that sentiment.
Yeah, the ratio of time spent writing notes and stuff back in the day was pretty small. And most of the time we spent was around patients or around each other.
I got to see lightly the era transition between paper and electronic, and I can tell you, getting to do both, I really miss doing paper charts. Terrible to look up information, terrible to read other people's handwriting, but at least I can get my notes done fairly quickly.
Sneha?
Yeah, thank you, Ben. This was a really great overview of a lot of data that's out there. And I agree with you. I think the Mayo papers have a really nice outline of all the different factors that go into this. I'm just curious if you have any thoughts about the similarities or differences between terms like burnout versus terms that are perhaps getting a little bit more buzz lately, things like moral injury, perhaps. That maybe gets a little bit more to that frustration and lack of an emotional reward that I think we're all feeling.
Yeah, I haven't spent a lot of time reviewing, and actually I talked with Ludke about the moral injury paradigm. I wasn't actually too keen or familiar about it until more recently. We all use a lot of words to attribute it to things. I'm not sure if the definition of moral injury is necessarily what defines the process as a whole. If it were to be something, I would probably speculate that could be a subcategory at best. There's just too many facets to really define it as one actual particular issue, is kind of just my thought on it.
Kevin?
Yeah, thanks. Great presentation, Ben. The chart, I agree with Rich. That chart right there says an immense amount about what has happened in medical practice and training. And I think the same thing, if you were to look at the number of residents in residency programs, while the numbers have increased slightly to to look at the volume of work that you're doing, especially with all the new systems that are set up that we didn't. I mean, you could write a whole list of 10 medications probably in a minute, and it's going to take you twice as long or longer to do that. So if you looked at all the time demands, the volume of consults, the volume of admissions, everything, all the other work that goes into it, I got a feeling you'd see something similar with residents being the green section and then the workload going up immensely. So it's a great way to sort of break it down and make it, because it gets locked into so much like, oh, how many hours do you need? And, you know, things like that. That's not looking at what the problem is. The problem is the volume of work.
Yeah, and I'll go on to say I agree with all of that. I think when it comes to clerical documentation, electronic health records has definitely made it much different than what it used to be. And on top of that, I feel like with every year we're doing this, there's always some extra metric I'm being tracked by, some extra piece of data that needs to be put in there, some extra item that needs to be documented. And by the end of the time, as you accumulate over the years, you have a health record document that previously took you maybe a minute or two to get through. Now it takes you 20 minutes, 30 minutes to write, depending on the complexity of the case.
There's no important content in it.
It's for someone else to track who's in this red category here.
All right, so we're going to do Janice, then Don. Janice?
Yes, I think this is a great presentation, first of all, and it's such a timely topic. So I really appreciate your presentation.
Thank you.
I do, as much as I hate to admit it, I do go back to the same era that Rich was speaking of, and there were some maybe subtle advantages that came from that era that may not be present currently. So I'm just sharing my thoughts about that. We rarely saw attendings, and this is from my experience both in Washington, at Georgetown, where I went to medical school, and also when I came to Duke to do my residency. And that is that the service was owned, like at Duke, it was stated that the service was owned by the medical interns, and that the attendings could not write in notes in the chart. And they were all to be handled by the intern who owned the patient. And that is such a difference in mentality than what we have today. But I think that, at least for me, the long hours where I felt totally responsible for a patient I'd seen in the ER, for example, with a evolving herniation from subdural, waiting for the neurosurgeons to show up. I learned so much, and I had that patient all night as well as other patients to go see, but they were my patients. I was responsible for them, and it really challenged me to the core all through my training to learn more. And I don't always see that. Occasionally, I think that we even see that someone sort of drags their feet a little bit until they're off shift and then can switch it to the incoming covering physician. So as much as those times were maybe physically difficult, they were exhilarating in many ways, to be able to go through something and see where I started 24 hours prior or 36 hours prior, and where I ended up at the end of just a one call session. So the amount of learning that took place and the sense of responsibility, I think, is hard to measure, but I will definitely give personal testimony to that it made me a very different person. So that a different physician, so that when I came out of that training, I found I was no longer, believe it or not, the quiet, shy person I had been when I went into it. I had much more confidence, and I had a body of knowledge that I had not had before. And not to say that some of that still does not go on, but those long days and nights and the long commitment that we knew up front that we were signing on for, I think was really a strong educational piece of our training. So, sorry, I could go on quite a
No,
bit
you're
with
fine.
that, but we did not have Epic, and I find Epic to be onerous. And every time they're going to have a new update, I just groan, because it is one more time when we are shifting from being physicians to being clerical people. And if there's one thing that I could really say is in need of closer eyes to look at, it would be the time that physicians spend on Epic and its worthiness or lack thereof. As notes get perpetrated one on top of the other, and none of them really give meaningful information, I hearken back to the time when people like Wayne Massey or Don Sanders, two I can pick on, would have and Marvin Rozier, 1 or 2 line note written in the chart that would encapsulate
Basically.
the essence of the case. So with that, I would say we need to see a me code for this as well, Rich. And then I'll get off.
I think it's posted in the comments.
Yeah, therapy code. Don, you can have the last question.
Thanks, Rich. I think I can legitimately claim to go back farther than anybody else as far as training. I think there are 2 major differences. One is, as Dennis alluded to, the authority that the house staff had. They had absolute authority over the management of the patients, and that authority went up from the intern all the way to the chief resident. And the other is lifestyle. Residency was your life. You were not expected to have an outside life, a family, for better or for worse. You were not expected to have to take care of a family or any other thing. So you worked 36 out of 48 hours, and your patients were your patients. You didn't hand them off to somebody else other than over that 24-hour period. Was that time better than now? You always think that the old days were the better ones, I think.
And I'm honestly not sure, because we all came from different points in time and training. And to kind of go back to Dr. Massey's comment, I agree. I feel like probably the most growth I had is when I had the most responsibility just upon my own shoulders on nights, doing consults as a JAR kind of by myself. I feel like that's when I kind of saw myself kind of grow as an individual. And I also agree that Epic is the bane of all existence, because I often find myself moaning and groaning, not when I'm actually seeing the consult, running around on the floor and whatnot. It's when I stop to sit down to type in front of my keyboard that I become upset with the time it takes me to get through a singular case or to see a consult that otherwise was pretty easy to do. It's the note that I have to do that's attached with that work order. But yeah. A lot of information, a lot of thoughts and opinions.
All right, Ben, great job. Thanks for all the input, everybody. And what we need here is some thoughtful solutions. And like I said earlier, yoga isn't one of them, at least for me. But the problem is the people in the brownish red there in your chart, they justify their existence by piling crap on the little green people there.
Yeah, no, and my other issue is the green people you can easily track by encounter volume. We need you to see a set number of 15 encounters a day in clinic. I can track you by that. I don't really have any metrics to track the red people by, and the red people often get to say, well, this is out of the scope of what I can do. We need to make a new position to fill this role, and then new administrative positions open and for an additional specific task. And then you also have complicated laws that require these individuals, which if laws could just be simplified, maybe we can have less of these people.
It's worse, Ben, because then the green people have to pay the salaries of the red people.
Right now, the red people are paying the green people's salaries.
Well, they're only giving them the check, but the money is by the green people.
Yes, but it's all about separating the workers from the means of production.
All right, everyone. Have a great day. Thank you so much, Ben.